Okay, I think we should get started. It gives me great pleasure in welcoming Dr. Raj Kapoor. I know all of you probably know him because he's been a tremendous resource for us on WhatsApp regarding COVID related questions, management issues. So, this is a perfect opportunity for us to listen to his insight into the disease process. And we really are truly blessed to have him here today to talk about this very difficult situation which has affected all of us in some way or the other. Dr. Kapoor does not need any introduction, but I will try to do my best. He is a pulmonologist based out of Pittsburgh. He is board certified in internal medicine, pulmonary critical care, and sleep medicine. And I think over the last year has spent a tremendous amount of time educating all of us about COVID, about its complications and about management strategies. Without further ado, I'll turn the mic up to Dr. Kapoor, but I have two housekeeping items I'd like to remind everybody. Number one, please keep your receivers, your computers muted during the presentation. And number two, if you have a question, you can use the chat box at the bottom of the screen. And also, you can raise your hand and either me or Nikhil will be able to get to you at the end of the presentation. And we'd like to ask those questions at the end so that Dr. Kapoor finishes presentation. With this, I will turn over the mic to Dr. Kapoor, and I will go ahead and mute myself as well.
Thank you, Ashish, for those kind words. I'm going to talk today about the practical management strategies of COVID-19. To understand this strategy, we have to understand the trinity of COVID-19. There are three important things we have to understand. One is infection, inflammation, and immunity. Let me start with the infection part. As we all know, that coronaviruses have been around us for many decades, and the horseshoe bat is the reservoir of coronaviruses. In 2002, it caused SARS-1. In 2012, it caused MERS. And in December 19, it caused COVID-19. So the coronavirus, there are about 7 coronaviruses that we know of. 4 of them cause upper respiratory infection because they only stay in the upper airway. And 3 of them go down in the lower airway, and that's why they cause severe respiratory syndrome or Middle Eastern respiratory syndrome. In 2002, when SARS-CoV-1 happened, there were 8,096 cases, 774 deaths in 29 countries. So the case fatality rate was 11%. In 2012, when MERS happened, 2,494 were affected, 858 fatalities in 27 countries, with a case fatality rate of 35.5%. Case fatality rate is calculated based on the population, not on the entire morbid cases. So in COVID-19, as of now, 168 million people have been affected. There have been close to 3.5 million deaths. It has affected 213 countries. And the case fatality rate, as you can see, is only 2.4%. So what that shows us is that out of the 3 pandemics, SARS and MERS were more virulent, whereas COVID-19 is more contagious. What happens is when a virus is very contagious, then it spreads very fast, but doesn't quite kill the host. And when the virus is very virulent, it kills the host, so it doesn't spread as much. The intermediary mammal has been civet in SARS, camel in MERS, and possibly pangolin or snake in COVID-19. And this issue has been still debated because we are quite not able to localize the virus in these mammals. So the way of transmission is, as we all know, is through small droplets or large droplets, which is aerosol transmission, direct contact, and also on some fomites, if you touch them and then touch your face, where the virus can last for about 24 hours. There can be accidental exposure in the lab. It's questionable through blood transfusion, it's questionable through organ transplant, and it is questionable through vertical transmission in pregnancy, although one case has been reported. So how to diagnose? We're all familiar with the PCR test. That is the gold standard for diagnosis. But the timing has to be right. As you know, that the first 5 days is the asymptomatic infection or the incubation period. And then the viral load increases. And it is in the next 7 days, that's when the PCR is going to be likely positive. The PCR is very, very sensitive test because it checks the RNA particle. If the PCR is negative, but there is a close contact or history of exposure, then one has to assume that the person has suffered COVID. Test may be repeated because 30% of the cases may not have it positive. There is another solution for that, that you can do an antigen test. An antigen test is less sensitive than the PCR. And this antigen test is a rapid test that you may be familiar with. Even though it is less sensitive, but it depends on the viral load. When the viral load is high, it's only then the antigen test becomes positive. So it's very sensitive for high viral load. It is very insensitive for low viral load. So this can come to your rescue if the PCR test is negative. The PCR will continue to be positive beyond 30 days, sometimes because the RNA particle degenerates and the PCR may be still being false positive. So the usual time is from the first day of symptom to 30 days of recovery. One can also do IgM, IgG antibodies, but these are more for recovery rather than for diagnosis. IgM comes out in 1 week and IgG comes out in 2 weeks after infection. IgM will disappear in about 3 weeks, whereas IgG will continue for many months to come. And that is why how you diagnose exposure to natural infection. We are all familiar with the symptoms, most important being fever, fatigue, chills, headache, nasal congestion, sore throat, productive cough, dry cough, shortness of breath. And then of course, 20% up to 20% can have diarrhea. That may be the only symptom. And you'll be surprised to know the people who have loss of smell sense, in almost 86%, they usually have mild COVID. They do not land up in the hospital for some reason, because I think that the virus is contained mostly in the upper airway because of robust immune response in these patients. COVID-19 affects the high-risk group other than the young individuals, but the incidence is very high in people with COPD, hypertension, diabetes, heart disease, kidney failure, elderly about 60s or 70s, anybody who has a weak immune system, and obesity. Obesity, these people have increased ACE2 enzyme expression. That is the reason they are very prone to COVID-19. This is the coronavirus structure, which is important to understand. This string here is the RNA, and the RNA is covered with a nucleocapsid, nuclear N protein. And this is the spike, which is a glycoprotein. So the S protein and the N protein are the most important. because these are the ones where the human body generates the antibodies. So if you look at the RNA, the N protein produces 70% of the IgM, IgG antibodies in natural infection, and 30% antibodies are created for S protein or the spike protein. The spike protein has a region which is called receptor binding domain, RBD. And it is this domain which is in the subunit 1 that attaches to the ACE2 receptor. And this is a domain that we are working on for looking for neutralizing antibodies produced by the vaccine. So this is the area of interest in the spike protein, which is called the receptor binding domain. So when the SARS-CoV-2 is inhaled or enters the upper airway and then enters the lungs, the spike protein is the key, and the angiotensin converting enzyme ACE2 is the lock. It's a lock and key mechanism. That is how it gains access inside the cell. And to do that, there is a transmembrane serine protease 2, which will prime the spine protein. And only then it can attach to the ACE2 receptor. This spike protein has got two parts. It has a head and it has a stem. It is the head which has the RBD, and this transmembrane serine protease 2 will prime the head away from the stem, and only when it is primed, that's when it will attach to the ACE2, and the virus will gain entry by endocytosis inside the cell. So once the coronavirus enters the cell, through the mechanism I just described, it goes inside and releases the RNA. And then the RNA, multiple copies are made of RNA, and their viral proteins are disintegrated. However, these proteins are reintegrated in the Golgi apparatus, and different virus particles are formed and extruded from the cell. Now, most of the mutations occur during this replication here, and that is the reason that the variants are formed. So for mutations to happen, the virus has to replicate. The virus is replicating more often once more people have infection. So if we contain the infection by vaccination, there will be less infection, less spread, and less replication of the virus, and less mutation and less variants will be formed. Coronavirus has already mutated more than 100,000 times. However, the more important variants which we see, they're about 1 to 2 per month. And that is the reason you have the India variant, Brazil variant, the New York variant, California variant, because the virus has had an opportunity to replicate again and again. It is this process of replication that we have to stop by all the measures of prevention and vaccination. The ACE receptor has expression in all the organs, as you can see, but predominantly it is in the kidneys and the small bowel and the testes in males. The ACE receptors are also there in heart and lung, but not as much. However, since the virus affects the lungs and the heart directly, and occasionally it goes into the GI tract with diarrhea, most of the problems occur in heart and lungs. What males should know that with high incidence of erectile dysfunction happens in people who have COVID, at least 6 times more. And I think it's an incentive for them to get vaccinated. this is the best message they can get, that vaccination is better than natural infection. So the ACE expression is occurring in all these organs, especially in the heart, where there's cardiomyocytes, endothelial cells, epicardial adipose cells. This is very important. It's in the endothelial cells. Endothelial cells line all the blood vessels throughout the body. And this is a major, major ACE2 expression, which is affected in COVID-19. The alveolar type 2 cells or the epithelial cells in the lungs are the prime target for coronavirus. And this leads to the respiratory insufficiency. So how does this ACE2 coupling lead to cell damage? This causes oxidative stress. What happens is that angiotensin 2 is converted to angiotensin 1,7 by ACE2 enzyme. Angiotensin 2 is the bad one, and angiotensin 1,7 is the good one. Because angiotensin 2 in excess will cause vasoconstriction, hypertension, and all the problems of renin-angiotensin system. And that's why we block it by using ARBs and ACE inhibitors. The angiotensin 1,7 causes vasodilatation, and it is useful for the body to have more angiotensin 1,7. And it inhibits the oxygen to reactive oxygen species formation. Oxygen, as you know, is converted to water through 4-electron transfer. And if there is a problem with electron transfer, then oxygen reactive species are produced. The superoxide, hydroxyl ion, and H2O2 or hydrogen peroxide. And when these accumulate, they cause oxidative stress and they cause the cell damage. So the angiotensin 2 will promote superoxide formation. The angiotensin 1,7 will decrease the superoxide formation, and SARS-CoV-2 will cause increased neutrophil infiltration, and the neutrophils will also cause, in attempting to kill the cell, they'll produce more superoxide. And this is the reason that we have to use antioxidants like vitamin D3 and melatonin that I allude to. And this oxidative stress is very detrimental because it will cause the free radicals to kill and cause cell death by apoptosis and necrosis. And not only that, this is going to cause, this oxidative stress will cause impaired RBC quality, platelet activation, and it will release from the endothelial cells coagulation factors, especially von Willebrand factor. And this is the one which causes the microthrombosis in the capillaries. So you see, one thing leads to another. So once the ACE2 is inhibited, there is more angiotensin 2 and decreased angiotensin 1,7. And this can lead to a lot of pathological damage in just about every organ. It'll decrease insulin sensitivity, it'll increase glucose uptake. COVID-19 and diabetes has a bidirectional relationship. People who are diabetics are more prone to COVID-19, and people who are not even diabetics can become diabetics. A friend of mine who was diabetic 2 has become diabetic 1 because of severe insulin resistance being lost and changed to insulin deficiency. Then there can be liver transaminitis, renal failure, of course, lung inflammation, and then endothelial dysfunction in the lung and cardiopulmonary dysfunction. In pancreas, it'll increase insulin secretion and cause inflammation. Brain does not have ACE2 receptors, but all the blood vessels in the brain are affected. And with the release of cytokines, there is inflammation of the brain. but it's not a direct effect of ACE2. In heart, we have increased oxygen species. Reactive oxygen species will cause inflammation, and this inflammation is the myocarditis, which is induced by the reactive oxygen species and cytokine release. So we have so many extra pulmonary manifestations of COVID, specifically thromboembolism, increased incidence of deep venous thrombosis, increased incidence of pulmonary embolism, even the catheter-related thrombosis. So there's a big coagulopathy going on here. In the heart, there will be cardiac arrhythmias, myocardial injury, myocarditis, cardiogenic shock, myocardial ischemia. In endocrine, I just discussed diabetic ketoacidosis, hyperglycemia. And then in GI, if it is involving the enterocytes, it will cause diarrhea and abdominal pain, acute kidney injury, and neurologic I addressed to is inflammation, encephalopathy, Guillain-Barré, myalgia, anosmia, stroke because of the vascular involvement. So we discussed about the infection part of the Trinity. Now let us discuss the inflammation part of the Trinity. So let us say tomorrow somebody comes to you and he says, Doc, I am COVID positive. What shall I do? Well, you tell him, there are two parameters that I want to monitor. One is your fever and one is your pulse ox. Well, if somebody doesn't have a pulse ox, then what do? Well, I'll monitor your shortness of breath. So these are the two important parameters, fever and shortness of breath. And this is very helpful, the pulse oximeter. Now, the problem with the pulse oximeter is that there is a thing called silent hypoxia or happy hypoxia in COVID-19, which people don't understand. What's happening is there is a disconnect between the arterial oxygenation and the oxygen saturation on the finger. And the reason for that is that the afferents going from the chemoreceptors and the mechanoreceptors to the brain are blocked by COVID or coronavirus. And because there is ACE2 receptors in the carotid body, it causes the afferents to be not conveying the message to the brain, to the respiratory center. And because of that, the sensation of dyspnea is not there, even though internally a person is hypoxic. So this is called silent hypoxia, which is very atypical otherwise, except in COVID-19. It also, the reason for this SpO2 normal and the saturation and the arterial oxygenation is low, the disconnect is because there is a shift of oxygen dissociation curve to the left, which increases the affinity for oxygen dissociation. And interestingly, even though there is arterial hypoxemia, the lung mechanics remain well preserved. And that's why you do not have a sense of dyspnea. And yet, within you have hypoxia. And this happy hypoxia is between saturation 90 to 94. So the pulse oximeter is very important to understand. Once the saturation hits 94 or below, up to 90%, I call it the yellow zone. Above 94% is the green zone, and below 90% is the red zone. So once the person is in the yellow zone, we have to take intervention steps. So let us see the course of the disease, what will happen when the person has presented to you, has fever and pulse ox monitored. 80% of them, after the infection, will have an immune system success and they will recover. Whereas 20% will land up in the hospital, and about 14%, 15% will recover in the hospital, and 5% will require ICU, and some of them will die. So as you can see, this is a major component of infection, that 80% recover because of immune system success. So the most important thing in the early phase is the person's immune system. And this depends on the innate immunity and the adaptive immunity. The innate immunity turns on within 2 hours after the infection. And the most important cell is the monocyte and the natural killer cell. And what they do is they produce a thing called interferon 1 and interferon 2. The word interferon means to interfere with something. And this interferon is to kill the virus. And this interferon response is the one which determines whether you will have mild disease, moderate disease, or severe disease. And if this innate system is strong and you have a good interferon response, obviously you'll contain the infection and there'll be a rapid recovery. On the other hand, if this response is weak, that's what happens, because in old age, in people who have comorbidities, people who are immunosuppressed, they do not mount a good interferon response. And in fact, this idea has been taken further to figure out interferon therapy in the early stage of the disease. And studies are going on right now to introduce that therapy. So interferon is released right away, and this is a good response, and that of the natural killer cells. This is the innate immune response, whereas the adaptive immune response takes almost a week to come on, and that is too late to contain the infection. So a study was done where they saw the interferon response in mild, severe, and critical patients. And long behold, they had a good response, they had mild disease. If they had poor response, they had severe disease. And even the INF activity showed the same thing. This is the mild case patient, moderate, and see the critical patient has hardly any interferon activity. This is very interesting that interferon is responsible for somebody to have severe disease or critical illness. In people who have interferon mutations, they do not mount any response. And some patients develop antibodies to the interferon. And these two factors are responsible, even in the young people, to get severe disease. As you may know, that most of the young people do not get severe disease, but there is a phenotype that they do. And the reason for that is they may develop antibodies to the interferon. And if there are no antibodies and there is no mutation of the interferon, you can see that there is a good interferon response in containing the disease. Now, this shows that as the body temperature increases, the interferon activity increases, which is beneficial for killing the infection. This is the natural defense that we have. And here we have all these physicians treating the fever. Let us treat it 102, 100. I get calls 24/7. Patient has fever. What shall I do? I say nothing. I've never seen anybody die of fever. Fever only kills when it is 105 or 106. I've only seen one case in my life. So they're treating this fever and cutting down the natural immunity, innate immunity response, and making the disease worse. And not only that, when they suppress and mask the fever, then I don't know if the patient has fever or no fever. You cannot even track the fever. So I hardly recommend anybody taking anything unless the temperature is more than 101. I would rather like it to be 103. I would not like to treat the fever till 103, and you will see great results. So here it shows that in young people who have low viral exposure, they have an early interferon response, the rapid viral clearance is there, and their disease is mild. In older adults, high viral exposure, if there is a delayed interferon response. So the viral load is very high, And this viral persistence and inflammation causes severe disease. Now, if there's a genetic mutation of the IFN pathways, then this response of viral load is very high and there's hardly interferon response. It will again lead to severe disease. Now, in this one here, if we give interferon therapy, then we can have a beneficial effect and make it a milder disease. So now that the virus has entered through the ACE receptor and it has overcome the interferon could not interfere. Instead, the coronavirus interfered with the interferon and made access inside the cell. It has done the angiotensin II activation, which will cause complement activation, reduction of angiotensin 1 and 7, which is a friendly thing, and then it'll invite all the lymphocytes and the myeloid cell activation to produce cytokines. And all this will lead to hypercoagulability and microangiopathy, which will lead to acute cardiac injury and lung injury, as well as direct viral invasion can occur in muscle cells. It can occur in kidney cells because they have very high expression of ACE2. That's why acute kidney injury is very common in COVID-19. So once the virus has entered the alveolus, it will invite a lot of polymorpholeukocytes, a lot of lymphocytes, platelets get activated. I explained you the endothelial cell, because of the oxidative stress, will cause liberation of von Willebrand factor, and this will cause microthrombi in the capillaries. And because of this, the D dimer will be elevated. As you can see, this is the von Willebrand factor, and the CRP will be liberated from the liver. It comes from the liver. So you see, in the lung itself, SARS-CoV-2 will cause damage to the alveolar cells type 2, and the type 2 cell produces surfactant. So that's a major injury in the alveolus. And besides that, there'll be a lot of macrophages, lymphocytes, neutrophil infiltration, and there'll be release of a lot of cytokines and thrombosis in the capillaries. This is microthrombosis. Now, there's lymphocyte sequestration in the lung, and I will even go ahead and say that this is a lymphocytic pneumonia. All the lymphocytes converge to the lung. And that is the reason that the neutrophil lymphocyte ratio becomes very pathogenic. So this is a microscopic finding. As you can see, this is the alveolar space. There is microthrombosis occurring in the capillary here. This capillary is open, and there's a lymphocyte which is flooding the gates here in the alveoli. And the endothelium is getting involved. It is an endothelialitis of the pulmonary capillaries, and it is the subendothelial release of von Willebrand factor 7. And then this is the gross appearance of the lung, which is very consolidated. And look at the lymphocytic pneumonia, all loaded with lymphocytes. And this is the electron microscope picture. This is angiogenesis. These are new capillaries forming by intersusception on each other. And this is the virus inside the endothelial cell right here. So they have located SARS-2 inside the cell. So there's diffuse alveolar damage. There is microthrombi formation in the pulmonary arterioles, as you can see, and they're clogging the circulation. And this is the reason for shunting of the blood. This is the reason for the yellow zone. This is the reason for the silent or the happy hypoxia. So if you treat the pneumonia and the lung in the stage 2, the lung surfactant produced by type 2 alveolar cells and the alveolar cells and the cytokine secretion is decreased by the measures we take, then the lung will recover. However, if the process continues with massive macrophage infiltration, alveolar macrophage activation. It will lead to cytokine storm or excess of cytokines being released. It will cause destruction of the type 2 alveolar cells, and there will be a severe loss of anti-inflammatory lung protective surfactant, which will cause the collapse of the alveoli. So because of this, there are two different kinds of phenotypes of lung involvement. When COVID-19 happened last year, initially in early part of the year, the physicians could not understand that they were trying to intubate these patients who had high compliance and very low VQ and low lung weight, and they did not have much recruitability of the alveoli because there was hardly any alveolar fluid or decrease or consolidation. Yet they were hypoxic, so they were putting them on mechanical ventilation, and that was the reason they were dying of iatrogenic death from mechanical ventilation in phenotype L. This information came from Italian autopsies when there was a Dr. Gattinoni in Italy. He autopsied all the lung patients who had died, and he figured out there are two types of respiratory insufficiency. In phenotype L, L stands for low elastance and high compliance, which is normal compliance. That means you do not need much pressure to increase the volume. And there is a low ventilation perfusion mismatch. The lung weight is low because there is not much fluid retention. And there is low recruitability because the alveoli are open. So why are you going to give PEEP and recruit more alveoli? They are already there. And this is the one which causes the ground glass opacity, which is usually in the periphery. And this ground glass opacity is thromboinflammatory disease. It is thrombosis associated with inflammation. It is thromboinflammatory ground glass opacities that you see in the CT scan. They are not very well seen in the chest X-ray. And of course, when the lung disease progresses, there is low compliance. This is your typical ARDS. And that is the reason you need high recruitability by PEEP or positive end expiratory pressure. So this distinction has changed our management strategy in patients with COVID-19. So the way I picture it is that when the symptom onset, initially, when the pulse ox is more than 94%, 95% and above, this is normal. And this is the viral infection phase. And it has not, this is the interferon has worked here very well. Now, when the saturation goes 94% to 90%, this is the L phenotype, where you see the pneumonia documented on the CT scan, ground glass appearance, is intrapulmonary shunting with edema and atelectasis, and ventilation perfusion mismatch. And there's release of intravascular van factor and 11, which is causing intravascular microthrombi. In addition, there is loss of lung perfusion regulation. Usually, hypoxia causes vasoconstriction. But besides the cytokine, there is also a bradykinin storm. This has not been addressed much, always say cytokine storm. I think there's a bradykinin storm as well, which is causing hypoxic vasoconstriction failure. And that is what's causing is more leak into the endothelial cells and the alveoli. And when this progresses, that's when the saturation starts to drop and you get the H phenotype or the ARDS with reduced lung compliance, increased dead space, increased consolidation and atelectasis, and of course, CO2 retention. And this is when the lung mechanics fail, anxiety and respiratory fatigue. So when it is N or normal, we use antivirals, and we do not want to reduce immunosuppression by treating fever, if you will. Here, we want to use anti-inflammatory and prone positioning and anticoagulation the moment this is L phenotype. And then when they get into the ARDS, There's lung protective ventilation, prone ventilation, and ECMO if needed. So as you can see, the oxygen therapy started here, but it is being replaced by mechanical ventilation as you proceed from L phenotype to H phenotype, because the lung mechanics start to fail here. So the third aspect of the trinity is the immunity. So immunity is a double-edged sword. If it is good for you, it will make you recover. But if it overshoots or becomes dysfunctional, then you will be in ICU and you'll be fighting for your life. So in mild to moderate COVID-19, what happens is there is efficient interferon response and activity, and there is increased viral clearance and resolution of the disease. And there's a regulated inflammation. There's a balance between the cytokine release and the anti-inflammatory. So this is a good anti-inflammatory cytokine release. Whereas in the severe to critical, the same thing becomes excessive and dysregulated. So there's impaired interferon response, production and activity. And then there is a viral persistence. And this leads to tissue damage, and then cytokine storm, hemotaxis of a lot of PNMs and monocytes, and then ARDS, and these cytokines, then they lead to multi-organ failure and death. So the COVID infection, this is the epithelial cells. It is going to cause the cell death because of oxidative stress, and then release all the cells will appear. They will release the cytokines. The cytokine storm will cause dysproductive cough, rhinorrhea, sore throat, initially hemoptysis, increasing fever, then the nausea, vomiting, lower GI, and then of course the brain will have all these problems. The cardiovascular will have heart palpitation, chest tightness, blood clots, heart attacks, cardiac inflammation. It's very important to check for troponin and BNP in cardiac patients. Anytime there is liver involvement, there will be increased inflammation and raised AST, ALT, and kidney. There's increased potassium excretion in acute kidney insufficiency, proteinuria, oliguria. And then, of course, I explained to you the microcirculation causing the happy hypoxia. So this is the sequence of events that it may cause no symptoms, it may cause mild symptoms, or if we cross over to the bad immunity side, we get cytokine storm, we get severe pneumonia leading to ARDS, it causes hypercoagulability, and microthrombi, rhabdomyolysis, microembolism, kidney infarction, myocardial infarction, hypervolemia, ARDS, mechanical ventilation required. Endothelial dysfunction is very important. As you know, endothelium lines all the vasculature. I believe the vasculature is about 4,000 miles in a human body. Imagine if you had to include that entire vasculature, and the coronavirus is damaging the endothelium. This endothelial dysfunction is the key to cause all the serious problems. And then, of course, acute kidney injury. The macrophages, dendritic cells, T cells, fibroblasts, endothelium, they release interferon gamma, TNF-alpha, IL-1, IL-6, IL-18, which cause all these damages. IL-6 is the most important of all the interleukin cytokines. So the neutrophil lymphocyte stressometer, which shows you that the ratio will continue to increase. So this can be a very good clinical marker of increasing neutrophil lymphocyte ratio. But mind you that when you give steroids to somebody, it will also increase neutrophil lymphocyte ratio. So this is without steroids. So it may confound the problem. These are different parameters that we measure: CRP, IL-6, D-dimer, and then NLR, ferritin, LDH, ESR. So most importantly, I would suggest that CRP when it is 100 and above, and IL-6 when it is 100 and above, easy to remember, that's when you're in very serious trouble. This is indicating that now you are going into critical phase. D-dimer, as you know, is 0.5. In some countries, they say it's 500. And when it is twice the normal, if it is more than 1, that's when you have to anticoagulate. So that's the marker right there. The moment it goes 1 and above, you have to anticoagulate. And then ferritin is going to be released. Ferritin will show you the cell damage and the release from the iron stores. And LDH is also the same enzyme, which is released from cell damage. ESR, as you know, is non-specific. With any inflammation, will continue to go up. In addition to that, we have to check troponin level and BNP, N-terminal BNP, because to make sure that there is no cardiac dysfunction. And as you know, because the inflammatory response can cause myocarditis. And even though it may not cause in the hospital, it may cause even after discharge. So now we have understood the trinity of infection, inflammation, and immunity. So how do we intervene? Well, the best thing we can do, of course, is to use monoclonal antibody. Monoclonal antibody has been a lifesaver. And as you know, this is to be given in the very first 10 days or less. Because what it does is it blocks the ACE2 receptor joining the coronavirus. It comes in between. So if there is excessive viral load and the virus has already entered the cell, it's not going to work. So it has to be given as early as possible in the first 10 days. Now, what are the indications for that? Anybody 65 years old, but anybody even 55 years old with heart disease, hypertension, lung disease, anybody even 18 years old with diabetes or kidney disease, BMI more than 35. Because BMI more than 35 has more ACE2 expression than BMI less than 25. And if a person is immunosuppressed, so all these people constitute a large group of people who can benefit from the monoclonal antibody. So monoclonal antibody initially was made by Lilly, only one of them, and Regeneron made 2 antibodies. So now Lilly also has made 2 antibodies, and this is called antibody cocktail. And the reason for that is that because of the variants, they may be affecting a different part of the RBD of the virus. That is why they're using 2 antibodies, monoclonal antibodies, to give you more protection against the variants. So this imdevimab and carcimimab is the Regeneron, and this bamlanivimab and atezolizumab is the Eli Lilly monoclonal antibodies. So now we have defined the green zone, the yellow zone, and the red zone. And our treatment will depend where the patient is. Incubation period, symptomatic. So here I would use freely, if I can choose to use monoclonal antibody. I would not like to treat the temperature here as much, and steroids are contraindicated here. If the saturation is above 90%, 5%, do not use steroids, because this is the phase of viral replication. And you're going to prolong the disease, and the viral will replicate again and again and cause increased viral load and persistence. Once the saturation drops to 94% or below, that's when you interject. Here, maybe you can use steroid, anticoagulant, remdesivir, oxygen, and prone position. And of course, when this goes into the red zone, the interjection will be assist ventilation, prone, maybe going to shock, we require vasopressor and ECMO. So this is the way that one should understand the infection, the inflammation, and the immunity. And according to the stage of the disease, that's how you intervene. When there's fever, malaise, cough, headache, and diarrhea, you try to use antiviral treatment, monoclonal antibody, maybe aspirin. I like to use melatonin and vitamin D because they're antioxidant. Remember, there's oxidative stress. and they're immunomodulators. People who are deficient in vitamin D have the highest mortality rate. This has been seen because vitamin D deficiency occurs usually in winter months. And all the people who died in Italy and Spain, they found a very great vitamin D deficiency. Vitamin D is a hormone, it is not a vitamin. And these two I always use in most patients because of antioxidant action, and they're also immunomodulators. So they favor your immune system in your for you. If you get into the pulmonary phase, then the steroid can be used. And of course, anticoagulation, melatonin, and vitamin D. A lot of people are using vitamin C and zinc. This is for epithelial integrity. But zinc overuse is very dangerous if it is more than 40 milligram elemental zinc. And I discourage the use of zinc. It's not required. Vitamin C, you can use up to 2000 milligram. However, for it to be anti-inflammatory and working on the immune system, the dose is almost 50 to 100 gram a day. And the studies are going on at this present time for high dose vitamin C, and it is not being used as such. Now, steroids, couple words. Number one, the recovery trial showed that dexamethasone 6 milligram orally or IV for 10 days is good enough. Why dexamethasone, whereas the world is using methylprednisolone? Well, the reason is that it's a long-acting steroid, number one. Number two, it does not have mineralocorticoid activity, because the steroid, when it has more mineralocorticoid activity, it will cause fluid retention, especially interstitial edema in the lung. So I like to use dexamethasone. Also, it has a biological half-life of 36 to 54 hours. That's why you only give it once a day. And here you have to give it twice a day. So the disease course, as you can see in the stage one can use remdesivir, but convalescent plasma is out. Today only the double-blind study came which says it is ineffective. Monoclonal antibodies is the answer. Fever, myalgia, anosmia, agusia, dry cough, diarrhea, headache. And this is where you have lymphopenia. This is a hallmark of stage one. There you use dexamethasone anticoagulation once there is dyspnea, encephalopathy, hypoxemia, and bilateral chest infiltrates. And here the markers may show you CRP, LDH, L6, D-dimer, and ferritin go up, but within mild to moderate elevations. But once it gets into the critical stage, there is severe D-dimer elevation, multi-organ failure, and troponin, creatinine, and all the other parameters go up. This is very important. If the D-dimer suddenly goes up, you must suspect pulmonary embolism. You must suspect DVT, because these patients are highly at risk for pulmonary embolism and DVT. And that is the reason that the anticoagulation is given to them even after hospital discharge. So in the end, I would like to say that to give you a perspective, in 1300, when the Black Death happened, the bubonic plague, 200 million people died. And then the smallpox, 56 million people died. Well, maybe the population was not as much, but Spanish flu, 40 to 50 million. Then as we come down, AIDS killed 25 to 35 million. And our coronavirus has killed so far 3.5 million. Even one single death is too much. But I'm just giving a perspective to compare as to that this pandemic has caused devastation, yet with our scientists making the vaccine and making the monoclonal antibodies within 6 months is amazing. I think they deserve a lot of credit and of course a Nobel Prize. I thank you for your attention.
Thank you very much, Dr. Kapoor. That was amazing talk about the coronavirus, and I think you really outlined and I think made it very clear to us about how this disease progresses. Now,